ওরে কি কি একটা ক্লাস্টার বলে ক্লাস্টার আমার একটা তো সপ্তর্ষি তোর পড়নি?
হ্যাঁ হ্যাঁ হ্যাঁ
Good evening, everybody. On behalf of the faculty of the CBME ENT in Ophthalmology, I would like all of you to be please welcome to this session. My first request to you all is please mute yourselves so that we can all enjoy the session. Am I audible?
Yes,
Thank you, sir.
yes, you can.
Thank you, sir. We would be doing this session in two parts today. The first is the clinical skills. And I think all the faculty members who are present here, ENT and ophthalmology, would agree that there is nothing more important to clinical skills training, which actually gives the true meaning to the competency-based medical education. Sir, I'm unable to change my slides, Uni sir.
What? Yeah. So
Just press the escape button
what should
once.
Sir, are you asking me to put the escape button?
Yes.
Sir, I'm not able to share. Should I stop share and share again?
It will take, sometimes this happens.
I'm sharing again, sir.
Okay. Yeah, but you should start the PowerPoint again.
Pardon, sir?
Start the PowerPoint, press the escape button and the PowerPoint will restart.
I'll do that, sir. I'll just give me a moment, please.
Yeah.
No, it's not moving.
I mean, sharing.
Sir, I'm sharing again, sir. Just give me a moment. I'm sharing again. Sir, it's sharing, right?
Not
Not
yet.
seen. Not yet. Not seen.
Not yet. Give me a moment, sir. I'll do it. I'll have to just redo the whole thing again. I'll do it. Is it visible now, sir? Is it visible now, sir?
Yes, it is visible.
Yes.
Yes, now I think there's changing. Okay, so we quickly go on to the learning objectives of the session today. At the end of the session, the participants should be able to understand the fundamental of clinical skills. I think all of us will agree. You will say, it's not that I don't know how to do tonometry. I can very well teach my students how to do tonometry. I think Rashmi ma'am will agree to me that she has been teaching tonometry by observing to her undergraduates and her postgraduates perform. For the ENT surgeons, I think all our students have been doing the tuning fork test, the bullseye examination. But what is so new about this clinical skills training? Now, the second objective would be that the participant should be able to understand the fundamentals of teaching learning methods of clinical skills. That means the same clinical skills, but now in a more organized way, we are going to be teaching them. We will have the lesson plan in front of us. We will have the teaching learning methods in front of us. The third learning objective would be the fundamentals of assessment. How are we going to assess our students? I think all of us would agree that as undergraduates, were we so well assessed for a tuning fork test? I still remember when I went to join my post-graduation in Pondicherry, my head asked me this question, what do you know about ENT? And my answer was, sir, all I know is that we use a bullseye lamp and a head mirror. That's a very famous cartoon. If you open up an ENT surgeon, put it on Google or anywhere, you'll find a very nice cartoon with a head mirror. So that's a very important skill for all ENT surgeons. The third would be the second part of our session, and that is the self-directed learning. Way back on 23rd of December 2019, the erstwhile Medical Council of India released the skill module, and that made everything very simple for us. What did they want to tell us by that? They wanted to tell us that we've already released the competency document. You already have your competency list. As far as for ENT and ophthalmology, we all have it in volume 3. We have our competencies, our outcomes, but the question arises, for which competencies do you want to plan a clinical skills session? That's what they want to tell us by that document. They use certain terms, and I would of course mention here that these terms have been taken by the document with the appropriate reference given at the bottom of the slide. We are quite familiar with these terms. We just close our eyes and ask ourselves, what is the skill? I mean, I would say, do I have the skill to make a nice biryani? My answer would be no. Do I have skill to make, am I skilled enough to make a nice Maggie? Yes, I am. So the question is that we want our undergraduates to possess the skills in ENT and ophthalmology as we will be moving towards the course. So what is the skill? It's the ability to perform a task leading to a predefined outcome. Please note the word predefined outcome. You've defined the outcome, which means the student should be able to perform the tuning fork test correctly. The student should be able to wear the headlamp and focus the light with the bull's eye lamp correctly. The second, the competency, which I think we are all very well versed with, very well explained by Uni sir, the habitual and judicial use of communication, knowledge, technical skills, clinical reasoning, attitude, values, and reflection in daily practice for the benefit of individual and the community being served. Competency, it just does not mean about a psychomotor skill we're talking about. It's a culmination of many things together. But we'll be introduced to new terms, something called DOAP. What is DOAP? It's demonstration, observation, assistance, and performance. Earlier, suppose we were teaching our students tuning fork test. I would please excuse myself from the ophthalmologist here. Most of my examples are taken from my subject. I happen to be an ENT surgeon myself. How are we teaching tuning fork test earlier? We used to be performing, we used to be telling the parts of the tuning fork, how to perform the tuning fork. We used to say you have to strike it at a particular surface, it has to be at a particular position. Student used to observe, and then we used to say, okay, now you're supposed to show it to us. Is there any place of practice there? No. Did we expect him or her to practice that? No. He or she observes and he or she is expected to perform. That's the gap I think the Board of Governors wants us to fill. We are supposed to demonstrate the skill. They are supposed to observe. We have to assist them to perform it, and then they will perform it. So that is called as DOAP. Now, once you have done or you have trained your student in a particular skill, You will be assessing them. I will be coming to that also. This assessment could be done in your ward. It could be done in the skill lab. It could be done in a lab for a few subjects because this document is applicable to everybody. So they have explained the terms pertaining to all the subjects. What they want to tell us is that the outcome for each phase is predefined. Very strongly speaking, this is applicable to major subjects like medicine, surgery, and gynecology. Because these are subjects that will start from second MBBS to final MBBS part 2. So for example, the skill of ECG starts right from physiology, goes up to, I think, pharmacology, pediatrics, medicine, and goes on. So they have defined the outcome for each phase. Of course, for ENT and ophthalmology, we won't be having that kind of a pattern. The skill sessions are planned for each predefined competencies. And a word we all have to now remember: repeated practice sessions in a safe environment. What do I mean? What do we mean by that? Of course, we all know that the Board of Governors has made it mandatory for all medical colleges to have a skills lab, clinical skills lab. They want the students to practice these skills in a safe environment. I still remember having put the urinary catheter first time, my junior resident of surgery showed it to me. And then I asked him, I said, sir, मैं क्या करूं? He said, patient में डाल दो. And that's exactly what I did. I straight away catheterized the patient. That's what the Board of Governors doesn't want our students to do anymore. They want them to practice it in a safe environment. That's the skill lab. And then they have to do it on the patients, or have to, that also under observance. So your patient is safe, your healthcare has improved, and your student has gained confidence to perform better. Now, again, this particular table has been taken from the skill document. The reference of the skill document will be provided as a resource material. It's very easily available. You just have to type the skills document and it's available on the site of the board of, that's the NMC. It talks about skills in two terms. Is a skill feasible to be performed in a medical college? Is it critical to be performed? What do I mean by critical? By critical, we talk about basic life support. You'll say definitely it's critical. I think all of us should know basic life support. I think all of us should know how to perform a CPR. But is it feasible that our students are able to perform it straight away on a patient? We will get the answer no. So for a skill like this, feasibility will be low, but definitely the criticality will be high. So such a skill could be performed with the help of a mannequin. Very interestingly, this document gives the example of a skill of diagnostic nasal endoscopy, once again pertaining to the subject of ENT. And it says that the criticality as well as the feasibility of a student to perform diagnostic nasal endoscopy, that's an undergraduate student, is again low critical and low feasible, which means our student should be able to know the steps of doing a diagnostic nasal endoscopy. All the ENT surgeons here would definitely agree with me. This is for undergraduates. For postgraduates, I think all of us have gone for cadaveric FES training, and we all learn a diagnostic nasal endoscopy and FES on the cadavers, but that's for a postgraduate. Now, this figure is from the skills document and tells us, making it simple, which skills would you, I would say, formulate a skills session. I think this question we are all going to ask ourselves. Competencies have been given. Now the question is, which will you perform? So the answer is going to be the competencies in which we have shows how and perform are the competencies for which you will be planning the skill session. It could be, once again, whether it is performing tuning fork test, whether it is doing anterior rhinoscopy, whether it is doing an indirect laryngoscopy, whether it is doing the examination of the oral cavity, whether it could be counseling a patient for the correct installation of the ear drops, or it could be counseling the patient for taking an informed consent. But these are the particular competencies which you will have to take out from the list of competencies to formulate the skills session. We will be taking you on a journey where we will be taking you on a session of timetable where you will find that all the competencies of ENT and ophthalmology respectively will be mapped out in the form of lectures, small group sessions, skill sessions, SDL, integration, and so on. Now, coming to the next, once again, this annexure, it has 3 annexures, this document. The annexure A talks about a particular session plan. What do you mean by that? I'll give you an example. I tried doing it myself today. Suppose I'm planning a sessions, say suppose for my students to know that they have to wear the headlight as well as the bullseye lamp has to be focused correctly. That is the session. So that is going to be the name of the lesson. The number of learners. We all know the skill sessions are carried out in small groups. Say I have about 20 to 25. What will be my objectives of the session? My primary teaching method, which of course is going to be, I'm going to be demonstrating, they are going to be observing, and after observing and assistance, they will be performing. What is going to be there for assessment? We all know that a very important method of assessment of skills is called as OSCE. The faculty members who have appeared for an DNB exam here, because we had DNB, ENT, ophthalmology, and pediatrics, has always had an OSCE for assessment. And I have been a DNB student myself, and I gave an OSCE exam way back in 2008. And I think an OSCE is a very good way of assessing our students. We are able to assess, I think, greater number of students in a lesser time with a wider range of questions that we have been asked. We have been regularly carrying out OSCE for our undergraduates. And in our team who carry out this particular OSCE, we have our postgraduates. So in turn, the postgraduates are also getting sensitized for carrying out the OSCE exam. Now, before we go on to the different teaching methods, I would just stop for about maybe 20 seconds and ask if there are any questions till now.
Hello.
Could I please request everybody else to please mute yourself? Somebody has received a call on the and who is online, please. Would request all.
Everybody please mute.
Thank you, Unisa. Okay, now going on to the teaching learning methods. I think when we are in a busy OPD, I think before the pandemic, we all remember, and I think where we had an OPD of say 100 patients in a day, and we are surrounded by undergraduates, and in between the undergraduate has to present a case of tuber tympanic disease, CSOM, or for example, maybe in case of ophthalmology, it could be a case of cataract which they are presenting. How much time do we give them? And how much attention do we give them? I think we all agree. We are busy seeing the patient. We're talking to the patient and then we stop. Okay, ab aap bataiye. So we talk to them and then they recite their history and we listen their history. We give our inputs and I mean, that's how we've all been doing it. But is that the correct method? So with that document, they've made it very simple for us. And we say that you can teach clinical skills by case presentations, chart stimulated recalls, a method called SNAPS, summarizing, narrowing the differential, analyzing the differential. Something we are going to be coming to self-directed learning, and 1 minute preceptor. 1 minute preceptor as a model fascinates me because 1 minute preceptor, if you hear the word, what comes to your mind? You'll say this method has to be taught in 1 minute. No, that's not what it is. 1 minute preceptor, the word was coined because actually during a discussion of a case, we are giving only 1 minute to discussing the case. I mean, the remaining about time, the student narrates the case, we give our inputs, but we are discussing for actually 1 minute. But actually talking, the 1 minute preceptor is broken up into many parts. First of all, we have to get a commitment. We probe for supportive evidence. Now, these terms will be sounding, I think, less relevant here. So I can give an example. Let's say CUM. So we ask, okay, what is your diagnosis? The student says chronic suppurative otitis media. Now I have to probe for supportive evidence. My question will be, what made you think that it is chronic suppurative otitis media safe type? My student gives me some answers that support the chronic suppurative TTD type. Then I will be giving him the general principle. I'll say why he progressed towards making the diagnosis of a tubertympanic disease. Then reinforce. I have to give him positive reinforcement. You made the diagnosis well, and you have been able to come to the correct diagnosis. You took the symptoms very well. Also, I have to give him constructive feedback. I need to tell him that you may have gone wrong somewhere. And that's exactly what you do in a 1 minute preceptor model. Interestingly, if you will ask yourselves and write down the points that I've just told you, you'll find that's exactly what we are doing, just in a more organized manner. That's all. Now, for the psychomotor skills, we have what is called as a Python's 4-step approach. And this particular model we have been using for our postgraduates for tracheostomy. And I think that's a life-saving skill. And I think everybody should know how to perform a tracheostomy. What is a 4-step approach? Normally, when we perform a skill, say a tracheostomy, we perform the tracheostomy, our postgraduate is just observing us. And I think after observing 3 or 4 tracheostomies, we expect the postgraduate to perform the tracheostomy his or herself. But I don't think that's the way it should be. So Python made it a little easy for us. He said, you demonstrate first without explaining anything. For example, I'm talking about NG tube insertion, nasogastric. So I insert the NG tube without saying any step. The second, I perform the NG tube, but this time with explanation. So I'll say, okay, I have to ensure that I have to measure the NG tube, and after measuring the NG tube, I tie the tape, I keep all my requirements in place, and then I pass the tube, patient swallows, now the tube is going down. The third step, now the student describes what has happened. So my student will be saying the third time, and I will be performing. And the fourth time, the student narrates and performs him or herself. Now imagine in this 4-step model, you have been able to layer the skill for the students. And that would have a much deeper impact and a learning experience for your students. Now, these are examples which I have already narrated during the session from ENT and ophthalmology. So I would not be touching on them. For all our participants, we will be coming back to each of the sessions we are covering on and off when we go on to form our learning objectives from the competencies, which is the main objective of this particular program. The second part of this session, and that is self-directed learning. I think self-directed learning is something which I think all of us are doing these days. And we've done it for the last 9 months since we were in the pandemic. We didn't have any official teaching for COVID. I think none of us had, whether it is us or anybody on the road also. But if you ask, even I think in Uttar Pradesh, you ask a rickshaw puller about COVID, he would be able to tell you at least 2 lines about COVID. Virus फैल रहा है और इस वायरस से होने से ये खतरे होते हैं. They are able to tell you that. So what have we done? We've all done a self-directed learning. We had webinars, we were giving material. We were all supposed to read that up, and we read it up because we started from scratch. When this COVID came, we knew nothing about COVID starting last year, January. But if you compare this year to January 2020 to January 21, I think all of us are bound to agree that we have done a master's program in something called COVID. And right now, the particular master's is going on vaccination. And asking ourselves, we would probably know more than the vaccinating officer also. So that's exactly what is self-directed learning. We have to arouse a kind of a curiosity in our student so that the student gets on to learning him or herself. That is self-directed learning, better called as directed self-learning, which means if I have to have a session on self-directed learning in, say, oral pre-malignant lesions for undergraduates, I would probably show them a video, the one which is played in the movie halls, that after having tobacco, patient can have buccal carcinoma, and then ultimately the patient dies. That arouses some kind of an interest in the student. So I'll say, what did you see in this video? Did you find something typical? Do you think anything is related to ENT? If something is related, you can refer to the books here. We can give them some resources. And I think they would be able to comprehend leukoplakia, erythroleukoplakia in a better manner than what we would teach them. Coming to this is a very famous quote from William Osler. And he who studies medicine without books sails in an uncharted sea. But he who studies medicine without patience does not go to the sea at all. I think all of us agree, and we have missed our patients terribly. No matter how much of online learning, online clinical skills, innovative methods, but I think all of us as clinicians, or I think pre or para branches, anything, we all agree there will be no substitute for clinical material ever. Now, so this all started way back, and there we had somebody called Malcolm Knowles who defined self-directed learning for us, in which a process is taken with or without the help of others in diagnosing their own learning needs. What is missing in yourself? Formulating your own goals, learning, choosing, and implementing appropriate learning strategies, and evaluating the learning outcomes. That means you are doing it for yourself. You are going to be making your own menu. How are you going to do it? This started by somebody called the Cyril Houle also. So you've had people like Malcolm Knowles and Cyril Houle who have been the educationists behind coming up with the concept of self-directed learning. I won't be going much into the slides for this. These are the stages of self-directed learning. I think this is something which was very important, and we all see ourselves there. Stage one, that is, the student is dependent and the teacher is authority or coach. I think we all recall that when we were in school, much younger, and you had a teacher who was very authoritative, but went on, you became interested, that you around your class 12th, you were interested. Your teacher becomes your motivator guide. You become involved, that's during your undergraduation of your medicine. Teacher becomes your facilitator. And finally, almost here in your final year, before your entrance for post-graduation, you have become self-directed, and your particular teacher has now taken the role of a consultant or a delegator. So I think all of us will focus that the student is moving from dependent to self-directed. That means there's a paradigm shift. The student is no longer dependent. We have to ensure that our teaching learning methodologies has to be student focused. Coming to this. Now, SDL in medical colleges, why, how, what will we achieve? We all know that these are something, I think we all agree, we have very people who would be much younger here, that when we started doing pharmacology, the particular antihistamine that was best available in the market was cetirizine. But I think all the ophthalmologists and ENT surgeons would agree here that there are very few of us who write cetirizine actually now. We all write levocetirizine, or we like fexofenadine. Why don't we use cetirizine? So there's always going to be an evolving knowledge. We have to give it to our students to have this particular kind of habit inculcated in them so that they continuously learn. That's something that's very important. It's possible that today your medical student who is with you may go on to do something very different, may go into a research specialty, may go into something which is very variant. So he has to get this habit of self-directed learning. Now, we all know that there will always be a change. There has been a change that towards the fact that now the student is not a passive learner. He's become an active learner, and all your methods have to be directed so that the student is involved. And your gravity has moved away from the teacher, closer to the student. Earlier, it was like, when we were students, if our professor used to be walking in the corridor, we don't walk anywhere around that. We just change our way and go to a different distance. But now, for our students, the millennial generation, we make it very different for them. We tell them that we are your mentors. We are always there for you. So the concept has totally changed. Now, of course, I think all of us will agree there are sure and certain advantages that are there. Now, the students will be more in tune with our natural processes of psychological developments. An essential aspect of maturing is developing the ability to take increasing responsibility of your own lives. We're giving them responsibility. We are giving them the onus that, okay, so we all realize the sooner they realize this, the better it is going for them. Now, of course, going on to that, this is your shift. That is from the teacher, you have become the facilitator, the motivator, and designer of the learning situation. And of course, most important, I always tell my students that you have to be a co-learner yourself. Sometimes your students, even during sessions, they teach you things. Now, the question is, how do we do that? Now, if you're supposed to plan a self-directed learning session in ENT in ophthalmology, I mean, that's something all of us will be wondering. I mean, what topics do you select? How do you plan the session? So what we did was, we looked for sessions basically which involved, we thought that these are topics which are more relevant to the society, more important to the community. They have to continue serving. In ENT, say something like hearing loss. So I think we all agree we have a hearing loss week. In cataract, of course, we have blindness and we have glaucoma. There's so many things. And these are young leaders. Where you think you have things which were more of community involvement, you can choose those topics for self-directed learning. Now, once you choose them, how do you do that? We take out a simple way. As we discussed, we plan a session for that. We give them, we can play a particular video for them which interests them. And this is very common. And what we did for them is that we played a particular video which had the young generation with a lot of them using their headphones. Our own undergraduate students from our college participated in the UP State Conference last year, and they won a prize also in this. And the topic that we gave them was basically noise pollution. And interestingly, all of them used a particular skit where they were using a lot of mobile with a lot of headphones. So they know that they're not supposed to do this particular thing. They became involved in that. We can have small group teaching, which we are doing, and we have something called as problem-based teaching. Instead of you going and telling them that this has to be done, you give them a lead, let them think, divide them in small groups, and give them a particular scenario. Let them build it on that. And you will be surprised to see that they will be able to come up with better things than what we can actually teach them. So this is about problem-based learning. And of course, students learn what they have identified. We all agree. They actually, what I've noticed is when the millennials come into our lecture theaters, they all come in with their iPads. They've all come with a preformed idea. Tomorrow morning, I have a lecture, and that's a revision of otology. And I know that they have already had preformed ideas. So I don't go and start teaching them. I start asking them what they expect out of this particular lecture. And when they keep telling me, I keep building on that. So we have to know that. The students then use the newly acquired knowledge to solve the problem, and they are able to remember it for a longer time, because we need to understand that whatever they are reading during their second MBBS or third MBBS part 1, this knowledge is also the foundation for what they'll be appearing for the NEET PG. So we have to give them that kind of a foundation. And of course, these are optional strategies, which I've already discussed. You can put them in small groups. You can have problem-based learning, and which you can involve your students in different way. And of course, you have a different achievement. They displayed a greater enthusiasm at the start of the clinical rotation, were often quick to inform their preceptors of the type of cases that they had or had not seen, identifying learning issues and learning needs more efficiently and effectively. A practical example that I have gone through, our students in Uttar Pradesh have recently joined back about 3 weeks back, and we finished one group of the particular posting. And I found that they were more interested in nasal cavity and otology, but a big segment in between, which comprised of oral cavity, oropharynx, and larynx, our students were not so familiar. And that was the period which was in between the lockdown. So the part which was in beginning and towards the end of the lockdown, they have all contributed. but we want them to tell us what is it that they want to learn. So they asked more questions, they were more likely to be spontaneous, read extra material, look up resources while in the clinic, thus being proactive, enhancing their own learning process. And this is something which we have all become. And whatever I am, I always owe it to my teachers. You are carving the next generation, the doctors who will be treating us. Thank you very much. And please, we are all open for questions. Onisa?
Yeah. Yes, sir. So, thank you, Radhaja. That was really well covered and well, the examples are all pinpoint. Again, ophthalmologists would kindly excuse the bias towards the ENT examples, I'm sure.
I know, sir.
Yeah. So this is one very relevant thing that has been covered today, and actually all of us will agree that to some extent all of this we have been practicing in our teaching methods in the OPD, but all these now, thanks to CBME and the what the MCI has laid out, become more, let's say, codified or become like become more clear cut. And as you showed in that one slide, which you showed very nicely about the today's lessons, what are the things I'm going to do? There's a chart given, so you can actually use that. You can actually have that chart in your hand or on your screen if it's on the system in the OPD, and you can enter a number of learners and those things. So all those things are, yeah, as Dr. Rashmi says, has become more structured now. So all those things are there, and self-directed learning was the other topic in this. So it's an important concept because we talk of undergraduate learning as andragogy. So we say that it's adult learning. So our students are all, we say they're all adults. So with that comes the idea of learning by themselves. So this again, I would like to just remind the first talk of CBME. One of the main things of the new curriculum CBME is outcomes based. So the whole point of the teaching and experience is not what the book says or what the teacher says. It's what the curriculum demands from the student. So our intended outcome is so and so. So it could, in case of ENT, it could be that we want a student to be identify hearing loss and be able to manage. So in ophthalmology, blindness and able to manage. So that is the outcome. So any which way that the student can achieve it is acceptable. So we should not be too hidebound saying that no, it has to be so and so book. It has to be my talk, which is the best in this thing, and it has to be that way that students be taught. Nothing like that. So it should be totally up to the student also to learn. Only thing is both the teacher and the learner should have the framework in mind or in their view. So that means when we say framework, we mean that both teacher and learner should be clear about what the outcome is, what the assessment method would be, and what would be expected at the end of that posting, that term, that year, that phase, and at the end. And Ratanjay, just one thing, if I may add, if you don't mind, regarding the SDL, because
Please,
just one
sir,
thing I
please.
note down in my this thing slide. Again, I think I've covered it in this thing. I just want to sort of codify the role of the teacher in SDL. So it is not that we are saying okay, SDL can also be done. No? SDL bhi ho sakta hai, aisa nahi. It should be a part. So role of the teacher, one thing becomes that the role of the teacher becomes to actually raise awareness on the role of SDL. So we should make our students aware that it's not just what the books tell you, or not just one book. It's not just one teacher teaching you. It's everything. You could learn from the patients. You could learn, just being in the OPD from even the staff nurse, or you could go. The whole concept of SDL has now become so easy and magnified because of the net. So there are so many options on the net also. So the teacher should raise awareness on the role of SDL. encourage learner participation, decision making. So this again happens in the OPD. So we can. It's not just us teaching the students. So we can just tell a few students could be told to be on their own in a clinic and just observe things, be in a procedure room and see what's happening, and then tell their recollections from that. So all that is part of SDL. And also one more thing is to establish the habit of self-monitoring. So students should also be told that it's fine that you are learning from other sources, but also get into the habit or do think of self-monitoring also of what you have learned, right? So that also is part of SDL. Then to encourage learners to reflect on what they did and to revise attempted work. So like maybe a few students in a particular class or in a particular OPD day, you have left them on their own. But at the end of that session, at the end of that day, they should be made to reflect on what they did. They were not with a teacher, they were not with a book, rather they were just on their own in the OPD, which means they could have been even at the reception counter, they could have been in a procedure room, they could have been talking to just one staff, they could have been talking to a few patients. But at the end of it, to reflect on it. So that also becomes a type of SDL. And then one which Dr. Anuja very clearly said is to bring the problem-based learning. So bring real-life problems into the classroom. When we say classroom, it is any teaching learning session, not just classroom. It could be in the OPD also or OT also. The students is there. So to bring real-life problems and then build from there as a way of SDL. So all of these things are part of SDL, which all of us should be aware of, and we should actively encourage all these things. Yeah. Over to the delegates. I think a few questions were coming up.
Dr. Unnikrishnan, Dr. Anuja, I think,
Yeah.
I think there are questions. No, I think both are Dr. Anuja's comments. Okay. So now, as I'll just like to add on something. Thank you, Dr. Anuja, for a really well-covered descriptive session about what exactly is involved. Now, to take a few examples of ophthal. Okay,
Yeah.
I'll just take a very simple skill, for example, vision recording. So whether a student is in ophthalmology, medicine, because it's testing a cranial nerve, or whether the student is an intern, this is one of the most basic skills. So as I look at my undergraduate, the Indian medical graduate, we often teach vision recording. But my experience has been, till we teach it in a structured, checklist-wise manner and assess them in the same manner, it doesn't really work well. They think they know what is vision recording, or in case of ENT, what is doing a tuning fork test. But the moment you put a structure to it, the flow of the order in which the thing should be done, the whether it is taking a consent, whether it is thanking a patient, whether it is explaining to a patient, the moment we teach them using that structured checklist, the things change a lot. Personally, in my department, my entire logbook since last 2 years, most of the ophthalmology skills we have been breaking it up and doing it using checklist. So the students, the teachers, everyone's attitude towards teaching skills has changed. Even the teachers found a difference in the way they were teaching. So I think this entire concept of what NMC is doing about skill training changes the moment we start adding objectives to it, and we keep the outcome in mind. So another example in ophthalmology would be simple things like vision recording. Tonometry is a skill which we don't really expect them to perform, but then we expect them just to know about it. So it doesn't go to a performance. Syringing is another thing which is not at a performance level, it's observation. Installation of eye drop is something similar to eardrop, is something which they are expected to do. So these are some of the things, as it is very obvious from the chart, the booklet. Okay, what is the level? And also from our own experience, we would be in a good position to decide whether it's an observation skill or a performance skill. Based on our entire logbooks, our teaching checklists, our assessment checklists would have to be designed. Exercises we'll be doing after these are over, that enlisting the things which require to be taught as skill, what level of competency to be taught. So I think, and one more thing is, like Dr. Anuja said, although she gave ENT examples, but it's not very different. Both ENT and Ophthal are very specialized branches. So we teach, the generals, the basics of our investigations and all to students. So we are almost, similar in those things. And SDL, though, of course, was very well covered, and Dr. Unni has added very nicely about some of the points or how to teach those or how to ensure SDL sessions. So thank you, Dr. Anuja.
Thank you, ma'am. Thank you. Thank you, ma'am. Thank you for all the examples. So that's helped it. Actually, ENT was born out of ophthalmology. So we anyway go hand to hand. It's the American society was actually together. So it was always it moves like that. And still today, I think many people in UP think the E stands for eye. So it's,
Yeah, there are sometimes
we
happens
are
Kerala also. Some they come with.
very true.
very true.
So, yeah. So, do we have any other questions from the participants or comments?
No, ma'am, not as yet.
Yeah. Yes, Dr. Sangeeta has mentioned, correct. We have developed OSCE station for visual assessment with checklist. Okay, right. Dr. Sangeeta, if I'm not wrong, you're an ophthalmologist, right? So I would advise you, go ahead and do that for simple skills such as gaze, ocular movements, anterior chamber depth estimation. So we normally don't think that these are individual skills. And exactly similarly, even in ENT, a simple thing like taking a consent before an examination, that itself is a big checklist. So we just need to open our minds and think, oh, does the student know this? Is this going to meet my outcome? So very true.
True, ma'am. And I think that's
Dr.
very.
Anuja, do we have any other things on the comment?
No, ma'am. I just wanted to add something that you said that I think out of doing more checklists, we are making, I think, more competent doctors. So we are in safe hands, I feel. They would know their work.
Yes, very true. Very true. So let's, hope that we develop good, competent things and in IMGs. Yeah.
Yeah, I know, ma'am. I know. Yes, ma'am. Any
So,
other questions? We are we are please welcoming any more questions.
or comments, if anybody would like
Yes,
to
yes,
share.
of course.
Please. Yeah. Okay. Okay, Sangeeta. All right. Okay. Yes.
Dr. Ajit, are you there? Dr. Ajit?
Yes, madam. Good evening, madam.
Please, good evening, good evening. Would you please like to add something?
Yes, ma'am. Just one thing on SDL. It was very nicely covered, madam. And generally, there is a misconception among many of the faculty members also that SDL means self-directed. It means it is just a time that we give give to the students so that they can learn themselves. But I think actually it is not like that. It is not just a time that they can utilize on their own to learn, but here the teacher and the student, they share the responsibility. So I think it is an example of a collaborative learning in which as the role of the teacher decreases, the role of the student increases. But many times there is some misconception that even students may feel that SDL is a time that they can utilize uh, on their own however they want. So it should not be a misconception. Otherwise, ma'am, everything else regarding SDL you have covered very nicely, madam.
I think that's a wonderful word that you've coined today, and that's collaborative learning. I think that's wonderful. It just sums it up all.
Yes, madam.
Vijayalakshmi, ma'am, would you like to add any point?
I don't think Vijay Lakshmi is joined today.
I
Yeah, I
think,
think
yes,
she's
ma'am,
not
maybe.
there.
Yes, ma'am, I think she's not there.
She's not
So
there.
if
I'm
there are
not
no,
very sure. Yeah.
I
Yeah.
think Sheenal ma'am is there. Sheenal ma'am, I saw a note from Sheenal ma'am.
Correct.
Yeah, good evening. Actually, I just wanted to put it there, like what we call as asynchronous learning. No? So, like we can put things on the mail or on WhatsApp, or if we have a Google Classroom, and student can go and go through that particular topic subject as and when it is convenient for them. So that I think is also a part of self-directed learning.
Yes, ma'am, that's very true. Any other points?
Sorry, I was typing something. There was a typo error. What was just now pointed out now, all SDLs should always be outcome directed. So
Yeah,
what,
that's what. Yeah.
yeah, very correctly mentioned by that, that this is a collaborative learning. In each session has to have an outcome which has to be achieved.
Yes,
So
ma'am, totally
not
agree on
just
that.
we sit and learn. So
Yes,
that's
ma'am,
a
totally
point
agree.
for this.
Yes, ma'am,
Very true.
totally agree for that.
Yeah.
Ma'am, if there are no other points, then I think we can end the session with everybody's permission.
Yes, I think looks fine.
Yes,
Dr.
madam.
Yeah.
Yes, I think we can end the session, and this is for all the participants. We will be meeting as from today, next Wednesday, every Wednesday, 7 p.m. That's right, Dr. Ajit? 7
Yes, madam.
p.m.
Yes,
Wednesday.
madam.
Yeah. Yes. Yes. Yes.
Yes,
Okay.
yes,
Yes.
madam.
Okay. Thank you, everybody. And
Yeah.
once
Thanks.
again, wishing everybody a very, very happy new year. And I think this year is going to be definitely happier.
Definitely, definitely.
Thank you,
Thank
madam.
you, by
Wishing you
God's grace.
to a very
Thank
happy
you.
new year. Thank you, madam.
Thank you. Everybody, please stay safe. Thank you. And
Okay.
good night, everybody.
Yeah.
Good
Thank
night.
you.
Good night.
Good night.
What was the weird D. D. These are